Welcome to the deep dive. We're here to, take all that complex information and really boil it down to what you need to know.
Exactly. It's about extracting the crucial knowledge.
And today, we're tackling a big one, acute myeloid leukemia, or AML. Think of this as your high-yield revision session.
That's the plan. We've gone through a really comprehensive set of revision notes on AML.
Okay.
And our mission today is clear. Give you a solid overview of AML, the definition, causes, symptoms, how it's managed. We want it to be clear, memorable, maybe even help with recall.
Perfect. Let's get straight into it then. AML. What's the fundamental definition we should start with?
Okay, so fundamentally, AML is a cancer. It starts in the bone marrow.
Right.
And the key feature is this block, this arrest in the development of blood cell precursors.
So they don't mature properly.
Precisely. These immature cells, the myeloid blasts, they just don't grow up and they start multiplying like crazy.
No.
And the number that clinches the diagnosis typically is having over 20% myeloid blasts in the bone marrow.
20%. Got it.
Yeah. And usually this is all driven by abnormal genes, often from changes in the chromosomes.
Okay, so genetic changes are key.
Absolutely. And, there are classification systems. The WHO uses genetics and morphology, how the cells look.
Right.
And the older FAB system was mostly based on just morphology, M0 to M7.
I remember those.
But the field's moving fast. Genomics, understanding the specific gene changes, is really refining how we understand AML and, crucially, how we treat it.
Makes sense. The more detailed, the better the targeting. So what actually causes AML? What kicks it off?
That's the million-dollar question sometimes. Often we don't know the exact trigger for a specific person.
Okay.
But we do know several factors play a role. There's definitely a genetic predisposition sometimes.
Like an inherited risk.
Sort of, yeah. And
Yeah.
we see a clear link with Down syndrome, for instance.
All right, I've heard that.
Then there are environmental factors. Exposure to significant radiation or certain chemicals, benzene being a classic example. Also, some inherited syndromes like Fanconi anemia increase the risk quite a bit.
Right.
And a really important one nowadays is previous treatment for other cancers.
Therapy-related AML.
Exactly. Previous chemotherapy or radiation can, unfortunately, sometimes lead to AML down the line.
And viruses. Any link there?
There's been some suggestion, maybe Epstein-Barr virus in some contexts, but it's less clear-cut than the others. For many cases, though, the cause remains, unknown.
So a mix of genetics, environment, previous treatments, but sometimes just bad luck, essentially.
That seems to be the picture, yes. And we can group these into more specific risk factors, things that definitely elevate the risk.
Okay, let's break those down. What are the main groups?
Well, first, having a pre-existing blood disorder, things like myelodysplastic syndromes, MDS.
Right, MBS is a big one?
Yeah, or aplastic anemia, myelofibrosis, PNH, even polycythemia vera. Basically, if the marrow is already struggling, it seems more vulnerable.
Like it's already primed for trouble.
Kind of, yeah. Then there's chronic myeloid leukemia, CML. That can sometimes transform into an AML-like blast phase.
Okay.
We mentioned radiation atomic bomb survivors historically, or patients treated with radiotherapy for conditions like ankylosing spondylitis. And certain congenital disorders, especially in kids' Bloom syndrome, Downs again, congenital neutropenia, Fanconi's, neurofibromatosis.
So several genetic conditions predisposed.
Yes. And rarely, in older adults, there's a pattern suggesting autosomal dominant inheritance.
Interesting.
Benzene exposure, as I mentioned, linked particularly to the M6 subtype, and then definitely prior cancer chemotherapy.
Which types?
Alkylating agents are known to increase risk, often via MDS first. And topoisomerase II inhibitors, they can cause AML faster, often with specific cytogenetic changes. The latency period varies a lot.
That's a lot of potential pathways. So,
Yeah.
okay, pathologically, what's happening inside the bone marrow? How does it develop?
Right. The core process is this runaway proliferation of the immature myeloid cells, the blasts. It all starts with genetic mutations happening in the very early cells, the hematopoietic stem cells or progenitor
The
cells.
source cells for all blood.
Exactly. And these mutations mess up the normal differentiation process. The cells get stuck.
Stuck as blasts.
Yes, stuck in that early stage, and they just keep dividing without the normal controls.
And they take up space.
They absolutely do. They proliferate and accumulate, crowding out the bone marrow.
Oh, okay.
And that prevents the normal production of everything else. Healthy red blood cells, mature white blood cells, platelets.
And that leads directly to the symptoms, I guess.
Precisely. Lack of red cells causes anemia fatigue, shortness of breath,
Right.
lack of platelets causes bleeding issues,
Okay.
and the lack of mature functional white cells, especially neutrophils, leads to a high risk of infections.
Got it. And you mentioned subtypes earlier.
Yes, crucially, AM isn't monolithic. There's huge genetic variability between cases. These different molecular subtypes influence how the disease behaves, the prognosis, and increasingly how we treat it.
Okay. So if someone presents with those kinds of symptoms, fatigue, infections, bleeding, what else could it be? What's on the differential diagnosis list?
Good question. Very important. You need to rule out other things. Top of the list is probably acute lymphoblastic leukemia, AL.
Different cell line.
Exactly. Lymphoid, not myeloid. Then MDS, myelodysplastic syndromes, similar features, but usually fewer blasts, less than 20%.
Okay.
Simple infections can sometimes cause temporary low counts and fever, mimicking things.
Right.
Aplastic anemia is key pancytopenia, low counts across the board, but for different reasons. Then a whole range of other blood disorders, ITP causing low platelets, HLH, which is an immune thing, other types of anemia.
Okay.
Rare bone marrow failure syndromes, maybe genetic ones. Sometimes drugs can cause low counts, drug-induced cytopenia.
Sure.
Even severe nutritional deficiencies like B12 or folate can cause cytopenias that might look suspicious initially. Autoimmune conditions like lupus, SLE can affect blood counts. Hemoglobinopathies like sickle cell can cause anemia. And sometimes other cancers like lymphomas can involve the marrow.
So a pretty wide net needs to be cast initially.
Definitely.
Yeah.
A thorough workup is essential.
Now, how common is AML overall? What's the epidemiology look like?
It's actually the most common acute leukemia in adults.
Okay, the most common acute one.
Yes. Here in the UK, the incidence is around 4 cases per 100,000 people each year. Interestingly, that's reported as the highest in Europe.
Wow. Okay. And age?
Age is a huge factor. It can happen at any age, technically, but the incidence climbs steeply as people get older.
Right.
The median age when someone's diagnosed is about 67.
67?
Yeah. And get this, in the UK, something like 42% of all new AML cases are diagnosed in people aged 75 or over.
42%. That's significant.
It really is. It highlights how important AML is becoming in our aging population.
Absolutely. So let's talk about how it presents. What are the typical clinical features? What might the patient notice, or what might a doctor find?
Okay, so the features generally come from 2 main things. The bone marrow failing to produce normal cells, or the leukemia cells infiltrating other organs.
Right, the crowding out effect again.
Exactly.
Yeah.
And the onset can differ. In younger people, it might be quite rapid symptoms developing over just days or weeks.
Quick.
Yeah. Whereas in older individuals, it might be more gradual, maybe weeks or months of increasing fatigue that they might put down to something else initially.
Like heart problems, maybe?
Sometimes, yeah.
Yeah.
Dizziness, exertional shortness of breath can mimic cardiac issues.
Okay. What specific symptoms should we listen for?
Well, related to anemia, fatigue, weakness, pallor, maybe that dizziness or shortness of breath, because of the low functional white cells, neutropenia, they might get recurrent infections or fevers that just don't clear up with usual antibiotics.
Stubborn fevers.
Yeah. Then bleeding easy bruising, petechia, which are those little red spots often on the legs. Nosebleeds, gum bleeding, heavy periods. Sometimes more serious bleeding can happen due to low platelets or DIC, disseminated intravascular coagulation.
Right, DIC is a risk.
It is. And that can cause life-threatening hemorrhage, say in the lungs, GI tract, or brain.
Serious?
Yeah. If the spleen gets infiltrated and enlarges splenomegaly, patients might feel full quickly or have discomfort in their upper left abdomen.
Right.
Very high white cell counts, what we call leukostasis, can cause problems too.
How high are we talking?
Usually over 100 times 10 to the 9 per liter. It makes the blood thick, sludgy.
Right.
That can lead to respiratory distress, confusion, altered mental state. It's an emergency.
Anything else?
Bone pain can occur too. Not always, but it can be a feature.
Okay. And on examination, what might you find?
You might see the pallor from anemia, signs of infection, the petechia or larger bruises, ecchymosis from the platelet issues or DIC. You might feel an enlarged liver, hepatomegaly, or spleen, splenomegaly. Interestingly, enlarged lymph nodes, lymphadenopathy, are actually less common in AML than in, say, ALL or lymphoma.
Good distinction.
Yeah. Rarely you can see skin infiltration called leukemia cutis. And sometimes the first sign might be swollen, bleeding gums, gingival hyperplasia, particularly with certain monocytic subtypes of AML.
Wow, okay. So a mix of symptoms and signs pointing towards bone marrow trouble.
Mhm.
How do we confirm the diagnosis? What investigations are key?
Right, so diagnosis involves blood tests first, then usually bone marrow tests.
Okay.
The full blood count, FBC, is crucial. It often shows anemia, low platelets, thrombocytopenia, and usually low neutrophils, neutropenia, though the total white count can be low, normal, or very high.
Variable white count.
Very variable. We'd also check a clotting screen to look for DIC.
Right.
Blood chemistry often shows high LDH and high uric acid. That's from the rapid turnover and breakdown of all those leukemia cells.
Okay, markers of cell turnover.
Exactly. And liver and kidney function tests are vital as a baseline before starting any chemotherapy.
Makes sense.
Electrolytes like potassium, calcium, magnesium might need checking too. And if there's fever, definitely blood cultures to hunt for infection.
Standard workup for suspected sepsis there.
Pretty much. But the definitive tests involve looking directly at the bone marrow.
The aspiration and biopsy.
Yes, bone marrow aspiration and tryphene biopsy. That's where we count the blasts needing over 20% for the AML diagnosis.
Right.
While doing that, we send samples for other crucial tests. HLA typing if a stem cell transplant might be on the cards.
Okay.
Cytochemical stains used to help classify the older M0, M7 subtypes. Flow cytometry is essential now. For detailed immunophenotyping, helps confirm myeloid lineage and classify subtypes.
Flow cytometry, okay.
And then the really important genetic tests, cytogenetics or karyotyping, to look for the big chromosome changes we talked about, like translocations or inversions. And FISH, fluorescence in situ hybridization, and molecular tests for specific gene mutations like FLT3, NPM1, CEP. These are critical for prognosis and treatment planning now.
So marrow exam plus detailed genetic profiling.
That's the core of modern AML diagnosis. We might also do a chest x-ray looking for infection or any heart issues.
Right.
And because some chemo drugs can affect the heart, baseline cardiac assessment is common, maybe an ECG and an MEGA scan or echocardiogram to check heart function.
Good planning. Okay, so AML is diagnosed, classified. What's the management strategy?
Treatment is usually pretty intensive and happens in phases. The first goal is to get the patient into remission.
Remission. Killing off most of the leukemia cells.
Exactly. That's the induction phase. It typically involves intensive chemotherapy. A common backbone is cytarabine, often given continuously or in high doses, combined with an anthracycline drug like daunorubicin or idarubicin.
The 7+3 regimen is a classic example, right?
That's a very common one, yes. 7 days of cytarabine, 3 days of an anthracycline. Sometimes other drugs are added, like gemtuzumab ozogamicin, depending on specific factors like CD33 expression.
Okay, what if that doesn't work? What if it's refractory?
If the AML doesn't go into remission after induction, that's refractory disease. The options then might involve different chemo drugs, perhaps higher doses of cytarabine, or combinations like slagida fludarabine, cytarabine GCSF, and idarubicin.
More intensive options.
Generally, yes. Assuming remission is achieved, the job isn't done.
Consolidation.
Exactly. Consolidation therapy is crucial to eliminate any residual leukemia cells hiding out and to prevent relapse.
How's that done?
It can involve several more cycles of chemotherapy, often using high-dose cytarabine. Or, for many patients, especially those with intermediate or higher-risk AML, an allogeneic stem cell transplant might be the best consolidation.
Using a donor stem cells.
Yes. An autologous transplant using the patient's own stem cells collected during remission is sometimes considered too, but less often now for AML compared to allogeneic.
Okay. And what about that subtype you mentioned, APL?
Ah, yes. Acute promyelocytic leukemia, that's a special case, M3 in the old system.
Yeah.
It has a specific translocation, T1517.
Right.
And the treatment is quite different and very effective now. It relies heavily on targeted agents.
Yep.
All trans, retinoic acid, ATRA, and arsenic trioxide, ATO.
Vitamin A derivative and arsenic.
Sounds strange, but they work by forcing the APL cells to differentiate and mature, often used with or without chemotherapy, depending on risk stratification. Outcomes for APL are generally much better now.
That's great progress. What about supportive care during all this?
Absolutely critical. Chemo wipes out healthy cells too, so patients need intensive support. Blood and platelet transfusions are standard. Prophylactic and therapeutic antibiotics and antifungals are vital because infection risk is so high. Medications like allopurinol or asburicase to prevent tumor lysis syndrome when treatment starts.
Right, the cell breakdown issue.
Yes. And things like strict hygiene, sometimes reverse barrier nursing, to minimize infection exposure. It's a huge part of getting patients through treatment safely.
After consolidation, is there maintenance?
For some patients, yes. For example, oral azacitidine has recently been approved as a maintenance therapy for certain patients in remission after induction consolidation who aren't going for transplant. It aims to prolong remission.
Okay, so induction, consolidation, maybe transplant, maybe maintenance, plus lots of support.
That's the general framework. Plus, other things might be needed, like leukapheresis for very high white counts initially, or specific treatments for complications.
Right.
It's very much tailored to the individual patient, their AML subtype, their age, and their overall fitness.
Understood. Given all that, what's the outlook? What influences the prognosis for AML?
It's really variable. Overall, survival rates have improved significantly over the last few decades, particularly for younger patients, those under 60 or 65.
That's positive.
It is, but it remains a very serious diagnosis, and outcomes for older patients, unfortunately, are still much poorer.
Right, the age factor again.
Yes. In children, though, the progress has been even more remarkable, with 5-year survival rates now up around 65% to 75%.
Okay. What specific factors predict how someone might do?
Several key things. The cytogenetics and molecular genetics are probably paramount now.
The chromosome changes and gene mutations.
Exactly. Certain chromosomal abnormalities are considered favorable risk, like the T821 and V16 and the T1517 of APL.
Okay.
Others are unfavorable or adverse risk. Similarly, with gene mutations, having an NPM1 mutation without FLT3-ITD is generally favorable.
Right.
Whereas having a FLT3-ITD mutation or TP53 mutation often means a poorer prognosis.
So the specific genetic fingerprint is huge.
Absolutely huge. Then, age-younger patients generally do better. The white blood cell count at diagnosis matters. Very high counts are often less favorable. Whether the leukemia has spread to the central nervous system is a poor prognostic sign. And whether the AML arose out of a prior condition like MDS, secondary AML, or after previous chemoradiation, therapy-related AML, those tend to have a worse outcomes than AML arising de novo.
So AML and TAML are tougher.
Generally, yes. So prognosis is complex based on integrating all these factors, plus how well the leukemia responds to the initial treatment. But our understanding is constantly improving.
It really sounds like that detailed molecular understanding is driving everything now.
It absolutely is. It allows for better risk stratification, guiding decisions like whether to pursue a stem cell transplant, and it's opening the door to more targeted therapies aimed at specific mutations.
This has been incredibly thorough, thank you. So to wrap up, AML is this complex, heterogeneous cancer originating in the bone marrow. Diverse causes, diverse presentations.
And increasingly personalized treatment strategies driven by understanding the underlying biology. Early, accurate diagnosis and tailored therapy are key.
Definitely. And it leaves you wondering, with the pace of genetic discovery, what breakthroughs might be next? Perhaps therapies that can target resistance mechanisms or even prevent relapse more effectively.
It's an exciting and vital area of research. There's always hope for better outcomes ahead.
Absolutely. Well, if you want to consolidate your own knowledge on AML or any other key medical topics for your exams, definitely check out passthemsra.com.
And for loads of free resources and questions, head over to freemsra.com.
Great resources. Thanks again for joining us on this deep dive into acute myeloid leukemia.